risk to the patient. Risk for us, because if anything happened with the patient, we will be at problem. The hospital will be at problem. Even our family will be in problem. So it's safety for everybody. It's not only for the patient. Of course, you could train for all rare and common things. Difference between simulation and real life. In real life, if you teach somebody and he made a mistake, you just have to intervene. In simulation, you could allow them to do mistakes, and maybe they will pick up on themselves if they miss something, and that's something different. You cannot do that. Of course, you could interact with different persons and personalities, because in each of us, there are different people, different times. You could bring those on during simulation. If Muhammad is scared from his chairman, that's his problem, but you could bring it in simulation as well. Doesn't matter where you look. Everybody talk about simulation-based education and outcome-based education. If you look in Canada, they designed the CAMMET, so we have to train doctors to do all of these things, and we have to train them and certify them. If you look at this ER physician procedures, those are the number of procedures that every ER physician has to do during training. Just look at the table here. It includes patient care or very well done simulation. Of course, to err is human. The number of people dying every year in the US is like 2 equivalent jumbo plane crashing every week. Of course, that's in the US. In our countries, is less. The author for that article said, licensing and certification for health professions should place greater emphasis on safety and performance skills. The chairman for the American board said the same, and since then the American Board of Internal Medicine is using performance assessment in their teaching and assessment. In Saudi Arabia, for the last 3 years, we revised all anesthesia curriculum. Now, in the anesthesia curriculum and in assessment, we have mandatory 26 workshops that every residents have to go through. And in 2 years' time, every anesthesiologist in Saudi Arabia have to go through recertification through simulation-based education. And that's just part of what we do. This is an example of boot camp that's held every year for all new residents, Jeddah, Riyadh, Dammam. They go through all patient safety education and complex machine check. Everybody go through the same, and that's the basis for the things that we got recognized for. Forms, simplest, like you don't find any sound boxer will go to a fight without part task. This is a good example of simulation. It's all used in many professions. It's not only anesthesia, flight simulation or medicine, military, business, nuclear power plant. It's very widely used, and it's the reason for safety. So there are different forms: verbal, standardized patient, part task, computer-based, and high-fidelity simulation. I'll just briefly talk about some of these things. Verbal and role-play standardized patients are very simple, cost little, but very effective for communication skill training and for counseling and decision-making. There are a lot of part tasks, and you're familiar with these. Every hospital has some for CPR, difficult airway, routine airway. You have computer-based simulation, electronic patient replica. You could have for the complex, TEE, cardiac, anything you could think of, you could have it. And the last example is high-fidelity simulation, in which you could reenact everything in real life into one program, and you could bring the stress and see the communication. These are the things to think about when we think about simulation centers. We could teach cognitive knowledge, skills, attitudes, and the most important thing, responses to crisis, situation, and team training. We could test individual readiness, team readiness, healthcare system readiness. Like this is some of the courses we've done with Ministry of Health in Jazan, the area of the war with Yemen nowadays. We conducted difficult airway training for the people who works in the border, who just get a lot of cases. We also did, in cooperation with the Ministry of Health, crisis management training. We are having a Hajj season, but can we wait for the first Ebola to come to Saudi Arabia? So we introduced these courses, Ebola preparation, like what they did in Europe and the States, to train people at our hospital, and at the Hajj season to be prepared for the first Ebola. So it's part of the system testing as well, and I'll be talking about this tomorrow in the in-situ simulation. So what are the equipments that are needed? Anything that you could discard from hospital, you could use it. Anything you use in hospital, you could use in simulation. What equipments? You could get things depends on the student's needs, learner needs. One very good application is crisis resource management training, either CRM or anesthesia or other types. Because we know that crises happen rarely, and most of the catastrophes happen with crisis management. And of course, this have been studied extensively in aviation, resulting in CRM, crew resource management. Those has been adopted and moved to medical application like crisis resource management. We know to get out of crisis, you have to have good knowledge and also good behaviors and teamwork. Like the cognitive components, know the environment, anticipate and plan, allocate attention wisely, and use cognitive aid, distribute the workload, have everybody in board. All these are CRM principles. Those are the elements that we teach and we learn and we pass it on. And that's what aviation do, and that's what we do in simulation. Usually we bring more than one discipline, so surgeons, obstetricians, anesthetists, nurses, RT, everybody come. And the focus most of the time in CRM principles. It's not on the knowledge and application and the use of knowledge. We have detailed debriefing after each sessions. When we run simulation, you cannot differentiate this from real life. Everybody is engaged. Usually there are a lot of challenges. You can't differentiate whether it's real life. People will have their all emotional stages, and the people will usually commit the same mistakes they would do in real life. Learning, as Dr. Muhammad said, it is the reflection. It is the mental map discussion, reflection on action and reflection in action. How would they do in the future? This is the focus of simulation, and that simulation could reform your future actions. Since we had the disasters in Hajj in the last season, now this is mandatory by Ministry of Health, and we do crisis training for everybody working in the season in Mecca, Medina, for heat strokes, crisis management. It's just part of the routine healthcare delivery. In the last 2 years, we've held 2 conferences. This was last year conference with National Sim Dowry, and a week ago we launched Saudi Society of Simulation in Healthcare, starting from anesthesia, now having everybody on board. So where this is applied, it's applied within and without anesthesia, inside and outside. We could apply the same principles, but anesthesiologists in every country leading the way in simulation training. In the last 3 minutes, I'll just explore some of the evidence. Is it effective? Does it work? What's the evidence? If you want to look from aviation, those are the number of accidents and projected number of traffic. If you see, by 2010, we should have had this number of traffic and this number of accidents. But these are the number of accidents that happen. And simulation played a big role. When we look at simulation or effectiveness of training, this is Kirkpatrick. So level 1, Kirkpatrick, is whether people happy with the training. Level 2, whether people learn. Level 3, change in outcomes and behavior. And number 4, the results. What's the outcome in the hospital? And number 5, money talk. Did we save money by good training? I'll show you some evidence from all levels. This is a meta-analysis about simulation and non-simulation education. It doesn't matter whether you look at level 1, level 2, level 3, always showing that simulation training supersedes others. Of course, there is a problem with assessment of competence because we didn't have normal test of competence, so you have to use simulation to test simulation or performance. But this is the bottom line by David Gaba. There is no industry waited for unequivocal proof that simulation is effective. There is no industry that high risk are not using simulation. And during last year meeting in San Diego, he's a Jewish. He used the verses from our Quran. وَمَنْ أَحْيَاهَا فَكَأَنَّمَا أَحْيَا النَّاسَ جَمِيعًا. If it's only one life that he saved, it's enough. And I could tell you personally, I've seen even my brother when he came to the ER. I resuscitated him with no cardiologist. I used CRM principles. So for me, that life have came, and I been told by our students that they saved a lot of lives using simulation-based education. Just a further evidence, this is a national study in the States, looked at 800 nurses. They replaced 50% of the curriculum with the control group, 25 with simulation, 50% with simulation. And they looked at their entry-level scores, community practice scores, and their national pass rate score. There were no difference. And now in the States, every nursing school, they doubled the intake for their nurses based on this study, and certification and recertification simulation has become even more, because we are approaching aviation in which up to 100% could be done by simulation in aviation before they fly. And this is a very strong. This is another study just came a year ago, looking at return of investment, because money talk. Everybody say, oh, this is expensive. So they've looked at academic medical center in the US. The cost of the training was $3.6 million. They had 3,000 people go through training. They've looked at the cost saving. They had 25% reduction in injuries, and they documented cost saving of 12 million to 28 million with the 3.5 million. So if the patient goals are the goal, achieved through education outcomes, education focused, not simulation. Simulation is a mean to do a goal. You have to build bridges and look what problems you need to solve. So to summarize, I think simulation is here to stay, grow, expand. It has good, sound educational principles, can overcome many obstacles to training, performance, and outcome-based education is now and the future. It needs intensive commitments from multiple users to make it cost-effective and to make it effective. No simple solution to improve patient safety. Simulation has major role. It needs cultural change. Yes, you could teach on patients, but you can't be very competent in everything on patients. Many forces are involved, me, you, and everybody. If you could be involved, I call you to do that. I was remembering when I got this card from my friend, Dr. Kaki, as a certified in life support, BLS. They were calling us to come to be instructors. We said no. So I call you, please. If you don't like to be tested, come join now to be instructor. So because I think simulation, certification, recertification will be coming to a theater near you. So you better join simulation because it's very interesting. And thank you very much.
Thank you very much, Dr. Muhammad Shamsa. Thank you. It was very nice lecture, and Doctor also did a very nice lecture. And thank you everybody who take a part in this conference and who make it this conference. Thank you everybody. And can I do one comment for your lecture? Yes. Okay. I have one comment and one question. So first, this lecture I am first time seeing this presentation because of this is very important presentation for ICU doctors and anesthesia and any medical specialist. Just imagine an anesthesia doctor before coming to OT and to start the case. It's like the pilot. It should be like the pilot of the airplane. For example, Kuwait Airlines. You are flying to Dubai, and captain of pilot is coming to you. There is 200 people sitting in the airplanes and saying, okay, we are flying to Dubai. God will save us. Don't worry. There is oxygen supply. Everything will be fine. Ameen. And everybody will escape from the airplane. And same, anesthesiologist is coming to patient, and during the assess the patient is seeing also for anesthesiologist. So he should come. Hi, salam alaikum, how are you? How are everybody? Everything is fine. So we will start our case. But inside the mind anesthesiologist, it's going a lot of things. So it may be difficult intubation. So I have to prepare something else. Mind is going, mind is running, but face is another phase. This is a very useful and very useful lecture. This one is. Thank you very much. So my question is, what about confidence? Is it useful for anesthesiologists? I mean, 100% confidence. And from where it's coming? Thank you.
Okay. Now, confidence plays an important role in your mental map. Overconfidence is the problem. It's not confidence. It's overconfidence that's the problem. And again, if you remember my slide, the ones that run into trouble are the most experienced ones, and those are the ones who will have difficulties in making the right decision because of their mental map. Overconfidence is the problem. And again, there's a phenomenon which is over-focusing. If you over-focus on a certain point in your management of a stressful situation, you might take the wrong decision. Now, how do you build up your confidence? Your confidence is built up by experience, number one, and by the right knowledge and preparation for situations. That's how your confidence is built up. If you go through the situation, if you know the right knowledge for that situation, and if you repeatedly go through it, you will find that your confidence will build up nicely. I was going to give you an example. All of us went through primary school, secondary school, and high school. And all of us memorized Juz' Amma, right? You're supposed to know it by heart, from the first verse all the way to the last one. How many of you know it now? If I ask you to recite it without reading it. Do you remember how many times we were repeating it and memorizing it and going to school? We forgot it all. It's the same thing with medical knowledge, exactly the same thing with medical knowledge and practice. You're going to forget the right decision to make when you're supposed to make the right decision.
Okay, any other question? Just we'll allow one question. Another comment from Dr. Abdulaziz.
I like the comment between about pilots, because I think we need to learn. I have another talk about processes to improve how we could learn from aviation. But do you think, the other question to ask yourself, do you think any captain or crew member in the airport or any company who would say, who's flying the next day or doing the next engineering for the next flight before he sent family to that airplane? If ex-pilot is flying, I'm not flying. Do you think that happened in aviation? That never happened, because they trust the system, the one that they work. Have you heard anybody ask